Thank you for joining us tonight for How MS Impacts Your Mood and Cognition. This webinar series is brought to you by Can Do Multiple Sclerosis. My name is Laura Allen. I'm the Associate Director of Programs here at Can Do MS, and I will be your moderator this evening. So, welcome to May and Mental Health Awareness Month. Our theme for May is staying on top of your mental health. Our monthly programs are going to continue to build on one another with 4 opportunities to connect with experts and peers. The last session of the month on May 25th will be dedicated to your questions answered on mood and cognition. We can address any unanswered questions you have during this interactive session. So again, our programs are going to focus on mental health this month, and that last session of the month when we meet, you'll have the opportunity to get your questions answered. So that format is going to change up a little bit, but it's still going to focus on mood and cognition. So we will save about 20 minutes at the end of this webinar for questions and answers. If you do have a question during the webinar, you can type it in using the question box found in your control panel. And the presentation is being recorded and will be archived on the Can Do MS website. You can also download a copy of the presentation and any additional resources from the control panel. Our speakers this evening are Meyer and Abby Hughes. Meyer is a rehabilitation psychologist and clinical researcher specializing in multiple sclerosis at the Johns Hopkins University School of Medicine. Her research and clinical focus is the cognitive and emotional symptoms common to multiple sclerosis. Thank you for joining us tonight, Megan.
Thanks for inviting me.
And we also have Abby Hughes. Abby is a clinical psychologist and an assistant professor of physical medicine and rehabilitation, also with Johns Hopkins. She specializes in rehabilitation psychology and MS rehabilitation. Thank you for being with us tonight, Abby.
Great to be here. Thank you.
And now I am going to turn the meeting over to Abby.
Good evening, everyone. I can see we have over 400 people joining us this evening, so welcome. It's so nice to have you all with us. I'll go through some learning objectives that we'll review together tonight. This is what we'll be spending our hour on, and I certainly welcome folks to put questions into the chat as well that we will try to address as we go through. The focus of tonight is understanding causes of mood and cognitive symptoms or changes in these symptoms in MS. We want to be able to recognize how mood and cognitive symptoms often overlap. We'll review some of the latest research on treatment recommendations. And finally, we'll learn some treatment options for symptom management strategies and where to find resources. In terms of an overview of mood and cognition, mood we will refer to as a person's emotional state at a particular time. There's lots of different words that we use around mood and emotion, so I think it's important to distinguish how these words differ a little bit. So for emotions usually refer to the brief feelings that we have in response to a particular event or people around us. Like, I felt relieved when my MRI showed no new lesions this year. So that feeling of relief is that brief emotion. Mood, on the other hand, is a longer lasting emotion and can include different emotions. Like, for the past week, I felt excited and nervous about going back to work after my recent relapse. Next slide, please. We know that depression is linked to MS. About 25 to 50% of people with MS will develop a form of depression sometime in their lifetime. The general population also experiences depression at a rate of about 20%. So in MS, this is an increased rate. For people with MS ages 18 to 45, there's about a 25% chance of developing a form of depression in the next year. Depression is more common in MS than in people without MS and in individuals with other types of long-term medical illnesses. Slide. And mood disorders and anxiety disorders are often linked and overlapping, so we often talk about them together. Anxiety disorders are also 3 times more common in people with MS compared to the general population, and up to 40% of people with MS do experience some kind of anxiety symptoms. Anxiety can exacerbate cognitive dysfunction, specifically in processing speed. And it increases that fight or flight response that we often have when we perceive some kind of threat. Unfortunately, when we experience anxiety, right, if we're thinking about a moment where we feel nervous or anxious or worried, that can also decrease our ability to solve problems or to really think clearly in the moment. So when we talk about mood symptoms and cognitive symptoms being linked, this is a perfect example of how that often happens. Slide.
So a little bit of background about mood and cognition in MS. I'm going to really focus on the cognition side of this. About 65% of people with multiple sclerosis experience cognitive changes in their lifetime. And again, as Abby mentioned with mood, we want to kind of give a definition here of what does cognition mean. Cognition is a person's mental processes that involve gaining and maintaining knowledge. It can involve things like thinking, reasoning, interpreting information, problem solving, organizing, learning new information, recalling previously learned information or memory, processing what you're hearing and seeing and experiencing, sensing around you in your world. So what you hear, you see, you feel, you taste, and language, being able to communicate with others and understand what others are trying to communicate to you. Okay. Oops. So, one thing that we wanted to focus on is kind of this overlap between mood and cognition. So we often kind of think about mood and cognition separately, but there's a very high overlap between these two symptoms. And you might have started to sense some of that from what we described earlier. But let me describe it in a little bit more detail. So sometimes we can have a cognitive experience or a lapse in our cognition. And sometimes I hear this a lot where people have an experience where they're having trouble finding their words. So that might be a cognitive lapse, or somebody reminds them that they had told that story before. So you have this change in cognition. You start to feel foggy or discouraged. And then you start to think about, oh no, how am I being perceived by others? You might withdraw socially, and then you start to have more mood symptoms, maybe feeling depressed, overwhelmed, anxious about how you're being perceived by others, or maybe even hopeless. The opposite can happen. It can happen in the opposite direction as well. As Abby mentioned, when you feel overwhelmed or stressed, that can lead to cognitive problems. And I often ask people to think about, did you ever experience a great loss, like the death of a loved one, and then felt like you couldn't really think afterwards or couldn't really process information as clear as you used to? So our mood can also have an impact on the way our cognition functions. So it's sort of this bi-directional relationship that's really important to be aware of, because one impacts the other. That means that we want treatments that can impact both, or one or the other, so that the other can also be improved.
So there's many factors that contribute to both mood and cognitive symptoms in MS. So many so that you might find that the font on this screen is a little bit too small to read. One of the questions that came through the chat from Brian was asking about the degree to which depression, for example, is a direct consequence of the brain changes that happen in MS as part of the disease process, versus other things like, adjusting to the fact that you are living with a chronic incurable disease, and that's a very upsetting thing to live through. So as you can see in this pinwheel, there are lots of different contributors, and both and many other factors can contribute to depression. The percentage of what contributes for each individual person might vary quite a bit. If someone, for example, has a great deal of brain atrophy in certain parts of the brain, that could actually directly influence mood. Whereas again, other people with maybe a history of depression prior to MS, or folks who maybe have lower skills in emotion regulation might be more prone to developing anxiety or depression in the presence of a new MS diagnosis. So if you look at these factors for mood, you can see that fatigue, substance use, pain, stress, sleep, all of these factors significantly contribute to mood. And that includes brain changes as a result of the disease process. Slide, please. And you'll see that the slide is almost identical for cognition. And this was very intentional in explaining how the brain, right, is our organ. It manages emotions, it manages thoughts, and it manages how we think through these processes. So the same things that affect mood often also affect cognition. One of the other questions that came through the chat was, what is the clinical definition of anxiety? And that's actually a great question. From a diagnosis standpoint, one would have to experience significant feelings of feeling nervous, anxious, on edge, irritable, worry. These are all symptoms that would lead to an anxiety disorder or a diagnosis for a chronic period of time that interferes with your functioning. Now, one can have anxiety symptoms without having an anxiety disorder or an anxiety diagnosis. So sometimes when we talk about anxiety, we think about that more temporary feeling that we all experience from time to time of feeling anxious. Whereas a clinical diagnosis of anxiety would usually come from a mental health professional based on an interview and going through your history. So these are the factors, again, in thinking of the complexities in your individual life that might contribute to mood symptoms or cognitive symptoms. Slide, please.
So I wanted to go through some specific examples of how what Abby just described shows up in real life. And this was actually adapted from a blog that's written by a person living with multiple sclerosis. And you can see here that he describes both mood and cognitive symptoms. So he said, simply trying to figure out and plan my day can be a big struggle. It can be anxiety provoking. I very much rely on a routine and my wife to get things done. Otherwise, I can sit for a very long time trying to figure out what to do first, which is frustrating. So as you can see, this person experienced cognitive changes, and those cognitive changes are triggering emotional symptoms that are distressing to them. For this one, we wanted to highlight that mood and cognition doesn't just impact the person with MS, but they can impact the entire family. So for here, a support partner might ask something like, do you want X or Y? Do you want chicken or pasta for dinner? And if a person with MS is experiencing processing speed difficulties, it might take them a little bit to process what was just asked and kind of figure out what the right response is. So they might pause for a minute. So that's why I said here, looking at the support partner, but doesn't respond right away, taking longer to process and get words out. And the support partner or the spouse might get frustrated and say, did you hear me? So it's probably frustrating for both parties here, where the person with MS is experiencing this cognitive delay as well as word finding problems. And the support partner perceives that as them not actually being heard or understood. So this can trigger emotions not only in the person living with these symptoms, but also a person who is around them, a family member. Finally, we wanted to highlight how this can also impact work. So for this example, a 48-year-old commercial lawyer with early secondary progressive MS, diagnosed 16 years ago, is having increased problems completing tasks on time due to cognitive issues. Her boss has pointed out that she has several late projects and is asking, is everything okay? She's worried that she may have to stop working. She's feeling like a failure at work and worrying about her job performance, which has led to her feeling hopeless and depressed. So again, some of these symptoms might be feeding into each other. So the more hopeless she feels, or the more she feels like a failure, that might be leading to more rumination about her work performance and leading to even more cognitive difficulties. But the two, as you can see with all three of these examples, cognition and mood really go hand in hand, which is why it's important to address both of them when you're experiencing these symptoms.
So there's been really an explosion of research when it comes to mood and cognition in MS over the past 10 to 15 years. Prior to 2000, if you look up research studies that addressed cognition and MS, you would be pretty hard pressed to find many studies. And for a long time, providers even denied that cognition or mood was even a part of MS. Fortunately, this has largely changed, and more providers are getting better with asking patients about their mood and about their cognition. But even then, some providers will not. And so as a patient or as a person living with MS, or maybe as a support partner, this is something that you can absolutely bring to your provider and continue to emphasize. In terms of other research studies that have looked at cognition, in addition to conducting studies on how people perform on cognitive tests, like tests of memory, tests of attention, tests of acquiring and recalling knowledge, there's also brain imaging studies that have looked at how brain matter and connections within the brain change when people are having cognitive difficulties. And what we see over time, in the image that you see on the right, HC, the far left brain, refers to a healthy control. The middle brain refers to someone with CIS or clinically isolated syndrome. And then on the far right is someone with relapsing remitting MS. And as you can see, this is a brain being activated during different tasks. And what often happens in MS is when a lesion occurs or when inflammation occurs in the brain, it can slow down the connections because the brain is becoming inflamed, and those connections that you would normally use to say, learn a new fact or try to recall something that you read recently, that network gets activated. In MS, if you have a lesion in that particular network, your brain has to work harder. It basically has to reroute around the part of the lesion. And so in some brains that are having more lesions or more inflammation or activity, you actually see an increase in activity. So for clinically isolated syndrome in this brain, this might be someone who is having an active lesion. Maybe this is their first MS episode right before they get diagnosed with MS, and you see more activation compared to someone without MS, and even compared to someone who has relapsing remitting, who let's say is on a disease-modifying therapy and hasn't had a relapse in a while. We know that the MRIs do show that the brain works harder to maintain that same kind of function, and that cognitive impairment can then lead to other kinds of difficulties like with employment, driving, or finances, and not just performance on a memory task. Unfortunately, there's not enough evidence showing that medications directly improve cognition. And this is usually a question that we get. Dr. Meyer and I are both psychologists, so we do not prescribe medications. We are not experts in pharmacology. So we're speaking to more knowledge of the research base here. But to our knowledge to this point, medications that say have been developed for Alzheimer's disease have had some preliminary testing in MS and have not shown efficacy for memory training. So this brings us to some other important pieces of why managing mood and managing health behaviors is by and large the most effective way we have right now for managing cognition in MS. Slide, please. We can also see this is a bit of a confusing graph, but if we take each line at a time, if you take the purple line that is starting to sweep upward, that is representative of brain changes over time, and particularly the worsening of MS over time. So going up is worse in this case. For someone who might have cognitive issues and does not undergo rehabilitation, that is the blue line you see, where someone starts off kind of high and they start to decline over time. And without rehabilitation, they continue to decline. Now let's take that same person and give them rehabilitation. Now that's the green line. You see that the person was starting to decline. They got some rehabilitation therapy and they improved. They still have some decline over time, but they're far delayed. It took them longer to experience that same decline. So that may be 10 more years of being able to work or to do the things that they want to do. And that dotted orange line represents a theoretical threshold of when someone notices cognitive impairment. We know that we do tend to benefit from focused strategies, and this is where a lot of the research has focused in the past 10 years or so on what does help with cognition. Some focused strategies, such as the Kessler Foundation Modified Story Memory Technique. This is a very specific strategy to help people with their memory. This is something that's been researched many times, and there's many papers on this, that is helpful for improving memory. There's also computerized training. Someone in the chat had asked about electronic training versus having an in-person training. And there are some programs that have shown improvement in people with MS. Aside from the brain training, we also know that physical exercise and psychological interventions to address mood have had significant improvement in cognition, sometimes even outperforming the computerized cognitive training for things like attention. A recent study by Dr. Prakash in Ohio showed that mindfulness training was actually more effective than attention training for improving cognition and emotion dysregulation. So it gets back to that idea that when we manage our mood and our cognition together, we do see improvements in both. Slide, please. We also know that people with MS and their support partners are both vulnerable to experiencing anxiety and depression symptoms. Dr. Meyer and I recently conducted a randomized controlled trial where we compared a peer support group to an emotion regulation skills group, or an ER group. And our preliminary results that hope to be published soon did show that people in the emotion regulation skills group improved more on their mood and emotion regulation skills, more so than a traditional peer support, even though people in both groups did report feeling better and did report some improvement. So taken together, this shows that using these mental skills, and particularly focusing on how we manage our emotions, can have significant effects on not only our mood, but also cognition. And sometimes these benefits can be even greater when we work together with our support partners.
So a psychologist or a mental health professional who has experience with both mood and cognitive symptoms can help you in one of two ways. They can help you learn strategies to manage difficult emotions, which can then improve your mood and then improve your cognition. So if you're feeling really down and depressed and you're having difficulty paying attention because of that depression, and we lift your depression, then the attention problems can be improved as well. Conversely, sometimes we can use strategies to help with cognition, to increase flexible thinking and apply emotion management when you have cognitive relapse or cognitive lapses. So for example, when you're having those word finding problems, taking some long, deep breaths to calm yourself down can get your executive functioning back online and then can get those words out. When we start to panic, we often experience even more difficulty getting our words out. So if we can use strategies to manage our emotions, that can often help with our cognition as well. And as Dr. Hughes mentioned, mindfulness has gotten a lot of press, and it really is very good, not only for managing emotions, but also for cognition. And I kind of think about mindfulness as a way that you can use mindfulness without sitting down and meditating. So an example I often give the people that I work with is, if you're in the shower, you can be thinking about all the things that you need to do that day, or all the things that happened yesterday, or you can be thinking about what the shampoo smells like, or what it feels like to wash your hair. That is a form of mindfulness. So it's noticing when your mind has traveled off and bringing it back to the present moment. That can help you when you're emotionally overwhelmed, kind of pulling your mind away from those worries about the future and back into the present moment. So that helps with emotions. It's also an exercise in attention, right? So if you are exercising, bringing your attention from one place to another, that is a cognitive exercise. So it does both, and that's a really it's a cool thing, and it doesn't have to be kind of a sit down and meditation, right? I also mentioned deep breathing in that first example, but we know when our heart rate gets above 90 to 100 beats per minute, our executive functioning or our planning and organizing starts to turn off. And when our planning and organizing starts to turn off, our cognition starts to turn off, and we're tunnel vision. We're only thinking about the thing that's stressing us out. So when we can bring our heart rate down, which is often by taking deep breaths, relaxing our muscles, trying to turn off that fight or flight response, that can also not only calm our emotions, but it can also bring our executive functioning and our problem solving skills back online. So we wanted to provide a few examples, and we're going to actually, after this slide, go through a few strategies together so that we can practice them. But one of the things that I've started teaching many of my patients is something called stop, relax, and restart. So when you're feeling overwhelmed, lost, or confused, and a few examples are you walk into a room and forgot why you went there, you can't find the word that you want to say, or you get unpleasant news. I've had a few patients recently talk to me about reading and having to reread, and they don't know what they just read. So when you're having those kinds of experiences, you want to stop and start to think about, what was I just doing before this? And what am I planning to do next? What is it that I'm actually doing right now? Kind of bring yourself, using those mindfulness skills, back to the present moment. Try to relax, calm your physiologic response by either taking a break if it's too overwhelming, taking some deep breaths, noticing your thoughts and your feelings. So am I beating myself up because I can't think of that word, and calling myself all kinds of names? And can I change that internal monologue to something that's more positive? Also, can you notice how your body feels? Is there tension anywhere in your body? Are you noticing kind of what's around you? So, if you can start to use some of these strategies to relax yourself, then you can kind of, again, bring that thinking back online and restart whatever it was that you were in the middle of. These strategies can apply to everyone. So while we have been sort of talking to the MS crowd, these strategies are just as effective for people without MS, like family members. I'm going to turn it over to Abby.
Okay, so you can see on your screen now that there's a pinwheel that is counting from 1 up to 6 or 7, excuse me. And what we're going to do is a practice together and practice taking a breath and holding it, and then breathing out and counting with that slide. So as this begins again, go ahead and follow the instructions on the screen where you breathe in, hold it, and breathe out. You'll notice that you're breathing in for a count of 4, holding it for a count of 7, and breathing out for a count of 8. The numbers are not incredibly important, other than it can often help to take a moment to hold the breath and to breathe out a little bit longer than you usually take to breathe in. What this does is it resets ourselves. The way that Dr. Meyer was just describing, of taking a pause or a timeout to refocus on the breath. Breathing is certainly not the only way to manage one's emotional distress, and it's not sufficient for managing emotional distress. I often talk to patients who experience a lot of irritation when they're told to just breathe, or to try yoga, or these things that can be really invalidating in the moment. So as we're practicing this breathing, know that this is not meant to cure your anxiety or emotional distress in this moment, but rather to give us a little space, a little distance from the intensity of that emotion. And it might give us some space to then use some other skills to manage those emotions maybe more effectively. And that can be done through working with a therapist. So why don't we go to the next slide, and we'll do a couple more of these exercises together. Go back one, yeah, there we go. You may have noticed during that breathing exercise, I was also talking. So your attention was divided between trying to focus on your breath and also listening to what I'm saying. And when we try to divide our attention in that way, it can be really challenging to be mindful or stay in the present moment. You may have been thinking of other things too. You may have had some noise interruption from the other room. My kid was just running around and I'm hearing her in the background, those kinds of things. So in asking yourself, is your mind feeling full of all the things in your life, or are you being mindful? Mindful meaning you're focusing on one thing at a time. And this image is a good example of that. Being mindful is not clearing your mind of everything and having a blank mind, because that's virtually impossible to have a blank mind. But rather it's a very focused effort placed on focusing on one particular thing, like the color of the flowers or the feeling of the warm sun. Why don't we try this again? And I won't talk as much this time. And let's go through 5 rounds of that breathing in, holding it, and breathing out. Maybe you can hear us breathing on the audio now. Why don't we go into the next slide? And I want you to observe perhaps what was different about the first time I asked you to breathe versus the second time. It's usually a little bit easier because we've taken a few breaths to slow down and to focus our attention. You might have focused on one particular aspect of sensations that you were having. Maybe taking a breath and noticing your feelings or thoughts, or noticing one of your senses. Sometimes we have difficulty integrating these senses because we feel overwhelmed. Like you might not notice a loud sound because you're focused on something else. In MS, I work with some patients who have really strong sensitivity to things like smell and sound. And these things can be pretty unpleasant or aversive and evoke almost an unpleasant emotional response. So sometimes using these mindfulness strategies can help develop a different kind of relationship with those symptoms so that they're less aversive and that you can focus on them in a way that is less disruptive to your emotional state and to your life if it is starting to interfere. Or you can also use distraction, meaning you are mindful of something else in that moment besides the sound that you find to be unpleasant. Why don't we do this one more time and pick one of your 5 senses to focus on. So you might find something on the wall to look at, or something in your visual range to look at, or something that you're smelling or hearing or feeling. I just happen to have a teeny tiny little seashell that I found on the beach that I'm going to use to focus my attention on when we do this exercise. Let's do this one more time. Okay, let's go ahead and move on. And just as a summary point for that exercise, when you did notice something, if you paid attention to something you were seeing or hearing, notice if your perception of that thing changed. In my example of the seashell, I happened to notice that it has a teeny line of blue on it, a different color that I had never noticed before. And this thing is on my desk every day. So it's an example of how mindfulness can help us notice things in our environment that we may not always be paying attention to.
I also think it's sometimes helpful that when you're doing these kinds of exercises, if they feel uncomfortable or aversive or annoying, because that comes up for many people, to sort of maybe just notice those feelings and get used to the sensation of those uncomfortable emotions as well, because we all experience uncomfortable emotions and many of us try to push them away because we don't like them, but sometimes getting used to having them there and having kind of a more friendly relationship with them can be really helpful. So again, we've just sort of scratched the surface of some initial ideas for how to address both mood and cognition, but we wanted to talk about what would you expect if you went and saw a therapist or a psychologist or mental health provider who has experience in both of these realms. Well, first, our initial appointment would be to help you build trust and a relationship with your provider. We'd want to review your history and find out what makes you unique and what your symptoms are and how they are unique to you and your environment. and to determine a personalized treatment plan, something that is specific to you, because each person, as we know, MS is the snowflake disease. Each person experiences MS in a slightly different way. And so we want to develop a plan that's unique to you and your needs. Throughout treatment, the idea would be to set goals and continue reviewing those goals to make sure that you're meeting them and that you're making progress. We also expect and want to encourage you to practice some of the exercises outside of treatment, because it's an hour out of a week or every 2 weeks, and you're living your life many, many more hours than that 1 hour that you're meeting with your provider. So practicing the exercises outside of it can really make a difference in terms of seeing progress. Another thing is problem solving around these kind of canned exercises. So clearly we went through some, and people have many different reactions, as we've highlighted. Some people love these exercises, some people hate them. And so a lot of it is kind of problem solving about what's the right exercise for you, and how do we make these exercises fit into your life so that they are useful to you. We also know that there's lots of different options. If we think back to that pinwheel, right, of all the different things that can impact cognition and mood, it can be very overwhelming to think of needing to address all of them. You don't have to address all of them at once, right? I often tell people, I'm going to give you a menu of different options. And what I want you to do is, just like if you're at a restaurant, pick the one that you think is going to have the biggest impact for you personally. If diet is something that's really important to you and you know that you can stick to that, then that's the thing that might be helpful. If meditation is something that speaks to you and you want to try that, great. If those things do not speak to you, then let's pick something else on that pinwheel. Making improvement in any of those areas can have a positive impact. So it's really about focusing on the thing that you know that is going to be easy for you to maintain. We also know that research studies usually focus on only 1 or 2 symptoms or 1 or 2 strategies for trying to improve these symptoms, and they often still highlight significant changes. So like we said, you don't have to do everything to see a change in your life. Also, your goals are yours, and it's really important that you focus on things that are important to you and not necessarily just the therapist. And also, goals can change. So some people that I work with come in and start working with me because they're having difficulty at work, and then they decide to retire early or leave the workforce. And so their goals may not be around cognition at work. Their goals might be around something completely different. So we want to make sure that your goals shift with you as life changes.
So there's many different places that we can go for information and for resources. I noticed a trend in the chat that some people were expressing that they have been referred for different kinds of therapies. Some people have a therapist that they work with. That's wonderful. Others may have been referred for testing, for example, and got the results of testing, but didn't necessarily follow up on the emotional side of things. So if you're looking for a provider, even if you've looked in the past and were not successful, these resources have improved dramatically in the past 2 to 3 years in terms of providers who are listing themselves as health psychologists, rehab psychologists. The National MS Society's Navigator program is a great place to start to look for MS-specific mental health professionals who can help. And mental health professionals are not a one-size-fits-all. I'll certainly admit that I'm not everyone's cup of tea when it comes to individual therapy. And so sometimes it takes trying out a provider to see if you click. And that doesn't necessarily mean that they don't know what they're doing. It means it's a relationship like anything else, that there has to be trust, and that you feel safe and that you can engage in that therapy. There's also sometimes limits in terms of your insurance or distance. And there are differences between psychologists, therapists, and psychiatrists, where psychiatrists are able to prescribe medication. Psychologist is a special term for people who've been through doctoral training in psychology. There are some master's level psychologists as well. And then a therapist is a general term that can refer to lots of different kinds of providers. So it's from an advocacy standpoint, and this is where that being a patient is often challenging because you also have to advocate for yourself in asking the kind of questions about what credentials someone may have. I know someone in the chat had also asked about whether therapy versus medication is more effective. And in general, we've generally shown that over time, over long periods of time, behavioral treatment tends to be more effective in the long term, because you're making, essentially, if you keep up with the strategies, you're making a permanent change in your behavior, whereas with medication, sometimes people can adjust to the medication over time. But honestly, this is a pretty messy area of research that we need more longitudinal or more long-term research to show these kinds of benefits. And that often the combination of medication and therapy for a lot of people is the right combination for that person. This is where precision medicine comes in, of individualized patient care, of finding out what works for you. There's also a lot of podcasts now. I think particularly during COVID, the podcast world has blown up more so than it was before. And there are podcasts from Can Do MS. There's a very popular podcast called Real Talk MS with John Strum. There's the MS Living Well podcast by the MS Living Well group. And these are all well attended. They tend to be, like these talks with Can Do, an expert, but also engaging people living with MS in these conversations. So I know I always learn a lot when I listen to the podcast as well. Just a quick note too, several people have asked in the chat about where they can get a copy of the slide deck. I believe that you can download the slide deck from the handout section of this webinar. If you're having trouble saving it to your computer or downloading it, or you can't find it, you can also email Can Do for a copy of the slides, and I'm certainly happy to provide that as well.
I think there's also going to be, this will be available as a an online webinar that you can rewatch later too.
Yep. All right, let's go ahead and go to the next slide. Just a few takeaway points here. We know that mood and cognitive symptoms are common for people with MS and their support partners, and these symptoms don't necessarily have to be caused by MS. They can be exacerbated by MS, or unfortunately, we also have other health conditions that can affect us in life. We might have ADHD, we might have heart failure, we might have other conditions that are also linked to cognitive changes or mood changes. That most of the interventions that we discussed today are actually beneficial, what we call transdiagnostically, or meaning across different diagnoses or different diseases or different conditions, with cognitive behavioral therapy being effective in most of these populations. So it's sometimes important to know what's contributing, right? Is it the MS? Is it the ADHD? Or is it these other symptoms? But oftentimes using a cognitive behavioral approach or seeing a therapist can be beneficial for both of them. We know that the mood and cognitive symptoms often interact, and that working with a psychologist or mental health provider can help with managing skills for all of these symptoms. Okay. Megan, as we were going through, I was trying to address some of the questions that came through the chat, either addressing them out loud or responding in the chat itself, but I know I did not get to all of them. So we have some time now to answer additional questions.
Absolutely. And first of all, I want to thank both of you for some great information that you provided this evening. And I do want to remind the audience that you will be asked to complete a survey that will pop up on your screen after the webinar is over. And I do encourage you to partake in that survey because it is useful information that helps us improve our programming. And I do want to clarify, you can download the slide deck from the handout section. And in addition, if you're having trouble downloading that slide deck, we will send out a follow-up email by the end of the day tomorrow that will have a link to the slide deck in it. So you'll be able to get it in that manner as well. And as Megan said, the archive of this webinar will be available on our website by the end of the day tomorrow as well. So that being said, you know, we did get a number of questions, and I know you just addressed this in the key takeaways, but people are asking how you can differentiate between cognition issues and age that are from MS and those that are from aging. So can you address that? for us?
I can take that one. Yeah, I think it's, many of the symptoms that people with MS experience are very similar to normal and even healthy aging declines. Starting in our late 20s, all of us decrease in our cognitive efficiency. And, one thing that we can do is cognitive testing. So when we referred to neuropsychological testing or cognitive testing earlier, that's one way that we can start to figure out whether this is age-related, so this is normal for your age, or if this is more due to MS. And that can be done with a neuropsychologist. It can be done, a screening can be done with your neurologist. Speech therapy and occupational therapy also do different kinds of testing.
Fantastic. So people are also asking about different types of healthcare providers. So one of our participants notes that they're seeing a social worker. And the question is, should they switch to a psychologist? So I know you briefly touched on the differences between mental health providers, but could you give us a better another explanation of that?
Sure, I can take that one. That's a great question. So social workers are usually master's level providers that can provide psychotherapy for things like mood and anxiety, depression, symptoms, general adjustment in life, right? Like general stress. You might ask your provider what their specialty is or what they have expertise in. My general rule of thumb is if I ever ask a provider what their expertise is and they say they do a bit of everything or they're an expert in everything, I run the other direction. If you've been working with someone and you've developed a really trusting relationship, right? It might be about MS, but you might have also had a death or a trauma or a grief that you're also processing through that therapy. Those providers are definitely trained to help with that. The main distinction where psychologists and neuropsychologists come into play is often with the cognitive rehabilitation piece. We tend to have more of that training in the brain and how the brain interacts with behavior, and what strategies might be helpful for enhancing memory, for example, in the presence of emotional distress, right? How do you focus on memory strategies or concentration strategies when you're also experiencing high levels of emotional distress, for example? And so I think it's a very personal choice of, do you feel like you have a good relationship with the person who's providing you your care? What is your goal of the care? And are you achieving that goal? If you feel like you've been in therapy for a year and you're not seeing a lot of improvement, then that's relevant. It might be worth having that conversation and saying, I'm not seeing a lot of improvement. I'm wondering if we can try something different, or maybe trying a different provider. And any provider worth their salt will be very understanding, or should be very understanding of that kind of request. I don't know, Megan, if you have anything to add on that.
Yeah, no, I was gonna say, I tell almost every single person, or I try to remember to tell every single person in one of our first sessions, that if you're not seeing a progress by even session 3 or 4, or feeling like the things that we're talking about are going to make a difference if you implement them, please be honest and tell me, because I would rather you meet your goals than just keep coming to see. And so I think it's important that if it's not the right fit with me, then somebody else might have another experience that could really move you forward. So yeah, just like Dr. Hughes said, if you're not seeing progress, I think it's worth exploring either some different strategies that person can provide, or a different therapist.
And I know we've been talking about cognition and mood as it pertains to MS, but one of our participants asked if anxiety is hereditary. So can you address that, Megan?
Sure. Yes and no. I mean, so there's a bit of a question mark there, and I think we see these kinds of symptoms, mood symptoms, anxiety, depression, are more common, and so there is probably a hereditary piece. But like with many things, it's not one-to-one. So just because a family member passed down, or you have a gene that makes you more susceptible to those kinds of symptoms, it doesn't mean that you necessarily will, or that you can never control it. So just like if you have a family member or family history of heart disease, certainly if you engage in certain lifestyle factors that will reduce your risk of heart disease, then you're less likely to have that symptom or that risk factor have an impact on you. So it's kind of a yes and no sort of answer. It's kind of a yes and answer. Do you have anything to add there, Abby?
The only other thing to add is to think of anxiety can also be a component of personality, and personality is highly genetically related. So if you think of yourself as maybe more controlling, or that you like things just so, that can be more along the personality side of things. So we call that trait anxiety. Then there's state anxiety, like being in a situation that is very stressful and having very legitimate, valid worry or anxiety in the presence of a stressor like the COVID pandemic or getting an MS diagnosis. So oftentimes people have the overlap of these two things. You might have some personality level anxiety combined with a situational stressor as well. And together those things may produce a level of anxiety that interferes with functioning.
Thanks, Abby. So we briefly touched on the role of the support partner. And so a question just came in that says, how do you handle or deal with your partner's lack of understanding of MS? What you're dealing with which causes you to become depressed, especially when your partner will not consider therapy?
Yeah, go ahead, Abby.
Yeah, so Megan and I are both looking at each other because one, we practice together, and oftentimes the question does become, my partner is struggling with this, or I'm struggling with this, and it becomes a couples issue. And so one thing that can be really helpful if you are trying to, if you think it would be helpful for your partner, whether they are the person with MS or not, to engage in therapy, if they're really resistant to it or have concerns about that, understanding what those concerns are, but also framing it in terms of why it would help you, right? For having that person go to therapy, right? What your ask is, because it might be that something is not wrong from their perspective, but that it could be something helpful to help the support partner. We probably don't have time to go into how to do this really effectively, but there are also other really great support partner-oriented webinars on Can Do that would be a great resource, because I think this question is actually addressed pretty comprehensively by Dr. Meyer and also Dr. Kalb, K-A-L-B.
Yeah. I also, I frequently recommend people they won't go, if their partner won't go to therapy, to attend Can Do webinars together so that they can learn about MS. And asking them to go to doctor's visits with you so that that person can ask the physician questions as well, and maybe can hear a little bit about things like fatigue or pain or things that aren't as visible and that your partner might not fully understand. But if you hear the doctor talking about it, or you hear other people with MS talking about it at Can Do events, that can help to open somebody's eyes or give them a little more education.
Fantastic. Thanks, Megan, and thank you, Abby, for some really informative information this evening. It's been a pleasure to have you on our webinar tonight, so thank you so very much. And as we conclude, I do want to remind you all of a few things. So, as you know, the webinar may be over, but we do hope that you stay connected with us. There are so many ways to stay connected with Can Do MS. You can stay connected with us through social media. You can look at our website, and you can also register for our monthly e-news by visiting cando-ms.org. And I am going to reiterate the information that I provided earlier about our May programs. It is Mental Health Awareness Month, and we are focusing on mental health this month for our Jumpstart and coaching programs. I would encourage you to attend those programs. And new this month is the last session of the month on May 25th is going to be your questions answered. So if we didn't get to answer your questions tonight, there's a couple things you can do. You can submit your question to the Ask the Can Do team, which is found on our website, or you can attend our last session of the month on May 25th for your questions answered. So we look forward to seeing you at some of our upcoming programs. Stay connected with us, be part of our community, and just be part of the family. So thank you for joining us. And as always, we do want to mention some additional resources that are available. One is the National MS Society, and the other is the MS Society of Canada. Both really wonderful resources to find information. And finally, I do want to remind you of our next webinar in June, which is Traveling and Recreating Safely. What a great time to be discussing traveling and recreating as we move into the summer months. So we do have some sources that are cited, and you can get those when you download the slides. And as always, I always like to thank our speakers for joining us this evening, but more importantly, I'd like to thank all of you out there for participating with us. It's so nice to have you. We had a really active crowd tonight in the question box, and thank you, Abby, for answering some of those questions as they came in, and it's been really great spending this hour together. So I want to thank you all and wish you a wonderful evening, and we'll see you next month for the webinar. But before that, we'll see you again for our Jumpstart and coaching programs.